I'm Roy Herbst, really excited to introduce our Grand Round speaker today. A special pleasure to introduce Dr. William O, who's just joined us. I can tell you Eric has just texted me and wanted me to emphasize how excited he and we all are to have William here. As you'll see as I introduce him, he certainly has a tremendous background and he'll be a great addition. Dr. O, he's now the Director of Precision Medicine for the Yale Cancer Center and Spinal Cancer Hospital. He'll be very involved in some of that work, and including our Precision Medicine Tumor Board. And he's, importantly, the Service Line Medical Director of Spinal Cancer Hospital at Greenwich. He received his medical degree from NYU. He was actually a Yale undergraduate and BS in molecular biophysics and biochemistry, and did his internship and residency at the Brigham and Women's Hospital and his clinical fellowship at the Dana-Farber, which is where I first met him. Before being at Yale, he was the Chief Medical Officer and Executive Vice President of the Prostate Cancer Foundation, where he focused on barriers to the delivery of care for prostate cancer nationally. William is a genitourinary oncologist, truly with decades of experience caring for patients with prostate cancer. For over a decade, he was Chief of Hematology and Medical Oncology, Deputy Director of the Tisch Cancer Institute and NCI Designated Center, and the Ezra Greenspan Professor of Clinical Cancer Therapeutics at the Icahn Medical School. That's Mount Sinai. He has a number of national roles that are quite relevant. He's chair of the American Cancer Society's National Prostate Cancer Roundtable, whose mission is to improve prostate cancer outcomes and survivorship through increasing awareness and equitable access to prevention, screening, and treatment. He's also chair of the Medical Advisory Council for the Chemotherapy Foundation. So what better way to welcome William to Yale, to have him give grand rounds. He's also part of the GU division. I think Dan Petrolak, I know, is online from a meeting he's at, and he's going to talk to us about new advances in prostate cancer in 2025. William, thank you.
Well, thank you, Roy, and thank you all for the welcome. Let's see here. These are my disclosures. I wanted to talk a little bit about my journey here. I actually worked with Roy as a resident. He doesn't remember that, but we were residents together. He was a year ahead of me, and then subsequently with Eric at the Dana-Farber and many friends. This was really key to part of my journey because as I moved on in my career, as you heard, I went to Mount Sinai about 15 years ago to build a new cancer center in New York City, and ultimately we did get NCI designation and renewed it. But part of my goal in life was to figure out how we actually deliver this care better to our patients because so much was happening and is happening. So I left my administrative roles to join a company called Semaphore, which was a spin out of Mount Sinai, which was really using genomics, but really more importantly, clinical data and AI to try to improve the way we deliver care to patients. And this will come up a little bit in my decision really to come back to academia to use information and data to better take care of our patients. It's a long story, but after 2 years at a publicly traded company, I joined the Prostate Cancer Foundation as the Chief Medical Officer, and I'll talk a little bit about the work that I did there in today's talk. But it all leads to, I think, a real opportunity for me to have joined the Yale Cancer Center in Smilo to talk about work that really in two big domains. One is, of course, prostate cancer, which I'm going to be focusing on today. And the second is how we deliver the care better, not just in prostate cancer, but to all cancer patients. And that's really that title around precision medicine. But today I'm going to focus on prostate cancer. These are the newest data from the American Cancer Society about the burden. It is the #1 cancer in men, really by far. 30% of all cancers are prostate cancer. And interestingly, even though we sometimes have a belief that prostate cancer is not lethal, it's still the second leading cause of cancer death. And not only that, the death rate is actually rising. This is as of 2025. Here's the incidence rates, and this is, again, really hot off the press. And you can see this very sharp increase in the incidence of prostate cancer. This is in and of itself quite an interesting conversation about why it's risen so sharply in the past decade. And we can talk a little bit more in the Q&A about what the implications there. And you can see the parallel in breast cancer, the breast cancer incidence rates rising. But the death rate from prostate cancer has, in fact, plateaued. And there's a lot of reasons to be concerned about this plateau. You know, early when I started in this field about 25 years ago, I thought that prostate cancer would actually, if you see this drop that you can see on this graph, I thought prostate cancer would fall below colorectal and other cancer death rates. But in fact, it has plateaued and, as I mentioned, is slowly rising. Of course, lung cancer death rates have gone down dramatically in men since the Surgeon General's report around cigarette smoking. And these are some of the data that have recently come out about why we're concerned about the death rate actually rising. If you look at the rates of cancer, you can see again that rise both in all groups, but also specifically in Black men who are denoted by the green dots here. But particularly, I want to point out this graph, the distant metastatic disease, and you can see two things here. One is the rate of metastatic prostate cancer is growing quite dramatically over the past decade. And one question is why? This is in the US, this is not worldwide. This is in a country where you could see that the rates of metastatic disease were dramatically dropping before this point. So what's happened over the past decade? And then you still see this huge disparity between Black men and all other races. And this is going to get at some of the work that I did, particularly at the Prostate Cancer Foundation. But I think a lot of us are concerned about these trends and about how we reverse them. Also last year, the Lancet Commission published a report about worldwide rates of prostate cancer. And what we know is that over the next 20 years or so, from 2020 to 2040, you can see in the corners here, the rates of prostate cancer will double. So the number of new cases will double, and the number of deaths will increase by 85%. And you can see a lot of it is driven in the orange bars by East Asia, South America, and other parts of the world. So we're seeing both an increase in incidence, but also a significant increase in death rates. And again, we can debate and discuss some of the underlying causes of this. This is not just a detection issue. This is a true concern, especially in an era where we have so many new therapies, which is what I'm going to shift my talk to. So I'm going to talk about 5 different areas today. I know that's a lot to cover in a 45, 50-minute talk, but I'm going to go through these because I wanted to just give you a sense of how much new information and new data and new treatments are really happening. But I'm going to start with this idea that screening is bad for prostate cancer. And this is unfortunately something that has taken hold and may be explaining some of the epidemiologic trends that you're seeing. What is risk-adapted screening? Well, I think part of this is conveyed by a very famous urologist who was a chair of urology at Memorial Sloan Kettering for many years, and unfortunately himself died of prostate cancer. But he had a lot of wisdom that he would talk about. One was, he said, growing old is invariably fatal, prostate cancer is less so. This gets to, from the 1970s and 80s, the idea that not all prostate cancers are lethal. The other thing that he said is cure possible for those for whom it is necessary, and is cure necessary for those in whom it is possible? What he's talking about is the heterogeneity of prostate cancer means that some men should be left alone to live their lives without intervention, and other men, no matter what we do, may progress and die of their disease. So when you think of a disease with such heterogeneity, how do we apply the right treatments and the right solutions to each of these patients? So we wrote an editorial, this is Sigrid Carlson and I, really talking about screening guidelines. And you're not meant to read this. I can tell you just that all of the major organizations that actually put out screening guidelines put out slightly different ones. So this is very complicated and unfortunately unaligned. Now, most primary care doctors and most insurance companies fund the recommendations of the U.S. Preventative Services Task Force, but the AUA, the American Cancer Society, the American Society of Clinical Oncology, NCCN, they all put out different guidelines. And you can see if you dig into this editorial that unfortunately all of the guidelines differ slightly. And you know, who's not going to be confused when you see all of this variation in terms of the guidelines? So when I joined the Prostate Cancer Foundation a few years ago, even though I'm a medical oncologist and I don't necessarily screen patients, I asked the question, where can I make the biggest difference in terms of reducing mortality from prostate cancer? So one of the first areas was this concept of risk-adapted screening. So we know, as I showed you in that earlier epidemiologic graph, Black men are one of the groups that has the highest rate of both diagnosis and death from cancer, and you can see that here. They actually have about a 2.2-fold higher risk of dying of prostate cancer. They present at younger ages, they have more aggressive disease, and are more likely to be diagnosed with advanced disease. So these racial disparities clearly exist, and this is clearly a population at risk. Now, there's an interesting conversation about the biology and genetics behind this and whether this is truly an access issue, a socioeconomic issue, or if it's truly a biological issue. But the bottom line is the self-reported Black men have the highest rates of dying of prostate cancer in the United States and actually in the world. So what we did was we simply created an expert group, a panel here, to review the evidence. Now, the issue is that if you try to only limit that evidence to randomized phase 3 trials, you'll be very disappointed because of the 3 randomized trials that have looked at screening, only 5% of one of the 3 trials actually had Black men enrolled. So here's a high-risk population who have just not been studied. So is the absence of evidence, does that mean that we shouldn't actually make recommendations that directly impact this population? And we decided no. We said we were going to look at all the evidence, but include evidence that included modeling evidence and observational data. So this paper was published in NEJM Evidence last year, and it asked 6 questions. You know, should Black men be screened? What should they know about screening? At what age? And so on. And I'm not going to go into detail about all this, but basically, most men are recommended to have screening at the age of 50 to 55. And even though the guidelines have always put Black men into an asterisk category, we took it out of the asterisk, and we just basically said Black men should get a baseline PSA between the ages of 40 and 45. And they should also get annual screening. I think there's a real opportunity, certainly nationally, but also here within the Yale network to really think about how we can have an impact on patients who are at the highest risk of both getting prostate cancer, but also dying of it. But as I mentioned earlier, some of the challenges here are how do we actually deliver this care? So when I left PCF, really it was as I thought about coming back to an academic medical center, it really requires this kind of partnership, really community leaders and academic centers. And I think that one of the organizations that I've been fortunate to be asked to join and lead is the ACS National Prostate Cancer Roundtable. And the idea really is to think about projects that will actually impact the disease in the exact way that I first started when I joined PCF. And so this started in September, more to come on this, and I'd love to interact with the community here to think about ways in which we can actually address this at-risk population. There are other at-risk populations, for example, those with a family history or genetic risk. I'm not going to have a chance to talk about that today, but I think that implementation is key. You can get all the great drugs in the world, you can have all these fancy new diagnostic tests, but if patients who can have access to basically a $50 test can actually learn if they might have a lethal cancer, I think that the answer is to try to find those patients. Okay, so we're going to switch to more advanced disease. And of course, this is the other way in which patients progress and unfortunately die of the disease. And I'm going to first talk about androgen receptor pathway inhibitors, what I call the first targeted therapy. You know, we talk about targeted therapy now. We have all these fancy biomarkers, but in truth, androgen receptor is one of the key first pathways. And you can see here that in pink are 4 what we call ARPIs, or androgen receptor pathway inhibitors, that are proven to improve survival in multiple disease states within the treatment landscape of prostate cancer. But this history goes back many years. In fact, there have been at least 2 Nobel Prizes awarded for the discovery that androgen was a driver of prostate cancer. Now, in 2025, we think it's obvious that androgen drives prostate cancer, but back when Dr. Huggins first did orchiectomies in patients with metastatic prostate cancer, it was not obvious that prostate cancer was driven by testosterone and androgen receptor. And this is a long history. The second Nobel Prize, by the way, was for the chemical synthesis of LHRH. And the idea here really is that this is a big disease for which this observation has not only led to a longstanding treatment, which we still use, so we don't use orchiectomy here in the United States. It's still used worldwide as a very inexpensive way to deprive the cancer of its ligand. But LHRH agonists and antagonists remain a mainstay of treatment, basically androgen deprivation. But what really we learned, when I started in this field, we said, you know what, we gave the patient leuprolide, their testosterone went down, we're done. we've maximized it. It turned out that we were completely wrong. And the reason we were completely wrong is that androgen continued to be an important driver of these cancers. And we now know that there are at least 4 drugs in this category of ARPI that block the continued signaling of androgen in these cancer cells. And they are listed here: abiraterone, apalutamide, darolutamide, and enzalutamide. We also know that chemotherapy has an impact when these cancers first present. We've known that for a while, but in fact, when you move it early into the presentation of metastatic prostate cancer, you can target this heterogeneity. Heterogeneity implies that these cancer cells are not uniform, monoclonal, like some leukemias may be. There are these different colored cancer cells. They're not really colored in real life, but they are driven by different driver mutations or abnormalities or sensitivity to androgen signaling. And if you have a better androgen signaling inhibitor or chemotherapy, that you can actually improve survival in these patients. And there have now been 11 prospective clinical trials. This is one of the most studied and most effective randomized stories that exist in modern oncology. Okay, 11 randomized clinical trials that show survival benefit for combination therapy in metastatic hormone-sensitive prostate cancer. So we call this HSPC, or hormone-sensitive prostate cancer, because we know that if we actually deprive these patients of androgen, as I showed you with Dr. Huggins, we can put these cancers into remission. But those patients would recur within a year or two. But what we've shown with all of these clinical trials is that if you do doublets, where you add an ARPI to androgen deprivation therapy, or you do triplets, where you add an ARPI plus chemotherapy, that you can actually improve survival. And you can see the hazard ratios there. You can improve survival by up to 20 to 40%. And all of these studies were positive. So the question is not if these drugs work. The question is there an optimal sequence? Is there one drug better than the other? But we're not going to talk about that. We're going to talk about the fact that all of these trials, including one that didn't even make it to this review article and was presented very recently, all show that these drugs should absolutely be used to improve survival. So, when I give talks to patients, I try to make the story simple, right? So ADT alone, going back to the 1940s, androgen deprivation alone, therapy alone was the standard of care. Then in the past few years, if you look at that graphic, we showed that chemotherapy plus ADT or one ARPI plus ADT improved survival. So 2 drugs were better than 1. Now the triplets showed that if you add a 3rd drug together, if you add ADT plus docetaxel, either abiraterone or darolutamide, you improve survival. So actually these 2 options should really be off the table now. And you'd be surprised. A lot of patients, in fact, do not receive these 3 options here. And these options are widely available. And we can talk again about why they're not always used. But sometimes it's the doctors themselves, maybe not in academic centers like ours, but in the community, who may or may not appreciate how important these drugs are in terms of overall survival. If you can live 40% longer with these treatments, why wouldn't you give these treatments? So they've asked that question in real-world studies, and this includes mostly U.S. studies, but also studies from other countries. And you can see that adding one of these drugs, either docetaxel or one of these, it's called RC here, but I mean ARPI, one of these extra drugs were more likely to be used in white patients, younger patients, in academic centers, and more likely by oncologists and urologists. But if you look at this graph that was published, it looks like we're doing pretty well. But in fact, if you actually put it on scale, this is what it really looks like. So we're lucky to get to 50%. At the time this was published, which was just last year, it was only about 30 to 40% were receiving a second drug. Okay, so this again gets to the same point I brought up earlier about implementation. We can get all these great drugs, but if patients aren't receiving it, they're not getting the survival benefit. And I want to call out that there are other drugs coming down this pike, including work developed here at Yale by Craig Cruz, the concept of PROTACs, AR degraders, and led by Dan Petrolak in the original clinical trials. And this was presented last year at ASCO, and you can see that this PROTAC that degrades AR, specifically in patients who have mutations in the ligand binding domain. It's beyond the scope of this discussion, but these are patients who do not respond to the current PIs that we have at this time. And you can see these waterfall plots, you see quite a dramatic benefit to the use of a degrader. So we're going to continue to see androgen signaling as an important target for anti-cancer therapy in prostate cancer. So here's a story that has evolved over not just a few decades, but over almost a century. We're coming, in the next 60, 70, 80 years, we've been using these treatments, but we think we're done, but we keep getting better and better, and you're going to see more of these drugs in that setting. Okay, so how else can we be better? Biomarkers are a hot topic. People talk about it all the time. That is the key to doing better precision medicine, right? So I'm going to talk a little bit about the story here in prostate cancer with regard to both molecular biomarkers and PARP inhibitors in particular. So in this graphic, there's two areas that are biomarker driven, PARP inhibitors and pembrolizumab. I'm going to just talk briefly about both. But this is an article from a few years ago that really shows the FDA approvals over the last 20 years and how many of them are really biomarker driven. You can see that the blue are biomarker driven approvals, and I couldn't find a more recent updated version, but it's probably continued and even more so. And you can see that in recent years, at least half of all drug approvals by the FDA are actually have an associated biomarker. And what this really points out is prostate cancer is not prostate cancer. Lung cancer, we know that's the prototypical story. It's not lung cancer. It's EGFR mutated lung cancer, or it's ROS fusion lung cancer. And the same thing is true in prostate cancer, except that we have fewer clear biomarkers. But this is an interesting paper also from last year from a prominent group that looked at the rates of molecularly driven treatment decisions. So this concept of targeted precision therapy. And we know that tier 1 and tier 2 mutations represent about, in 2017, represented about 9% of all patients presenting across the board, all cancers. And that went up to 31.6% 5 years later. Okay, and similarly, the number of undetermined drivers or drivers without actionability went down by about half. So you might say, depending on your point of view in the world, are you a half full or half empty person? Going from 9% to 31% in just 5 years is pretty dramatic. But 2/3 of patients still don't have actionable mutations if you do sequencing of their tumors. And this paper came out of Memorial Sloan Kettering. So the question is, in the average community practice, if they're not doing all of this sequencing, are they getting the benefit of these actionable mutations? It turns out prostate cancer is driven by molecular alterations, most importantly, DNA damage repair mutations or DDR mutations. And you can see here, if you look at the mutations, BRCA2 is the most common one. So this sometimes surprises patients because BRCA, of course, BRCA was named after breast cancer, but this gene in prostate cancer patients is associated with both a worse prognosis, earlier diagnosis, but also significantly worse outcomes. And if you look at these, about a quarter of patients with advanced prostate cancer, or CRPC, castration-resistant prostate cancer, have a mutation in one of these DNA damage repair mutations. 50% of those are germline, meaning they inherited it from their mother or father, and 50% are somatic, meaning they developed it during their lifetime. One of the things that we've learned, certainly from preclinical work, is that there probably is a synergy between androgen signaling and blocking androgen signaling and these DNA damage repair mutations. And so the hypothesis based on preclinical work was that combining an ARPI with a PARP inhibitor would actually improve outcomes in patients with prostate cancer. So three trials recently, about a year ago, actually a few years ago, have shown that survival is improved if you actually combine a PARP inhibitor with one of these androgen receptor pathway inhibitors. And this is one of the studies, PROPEL, which combined olaparib with abiraterone versus placebo plus abiraterone. And you can see that, particularly in the BRCA mutated subset, a very significant improvement, in this case, in overall survival. So we know that if you carry one of these mutations, you should be getting a PARP inhibitor, but more importantly, you should be getting it right up front. You shouldn't be getting it later. This drug was approved quite a number of years ago if you progressed after a drug like abiraterone, but now these studies seem to suggest that you should be getting them right up front, right at the time of metastatic disease. And a second study that is really in flight right at this moment is TALAPRO-2. Again, a different PARP inhibitor called talazoparib, combined with enzalutamide versus placebo plus enzalutamide. Again, a very similar endpoint, which is radiographic progression-free survival. And you can see that in all patients, there is a benefit to the combo, but more significant in HRR or DDR deficient tumors. They did put out a press release that suggests that maybe this combination works in all comers. I think we have to wait and see when that data is presented. So the FDA has now approved at least 3 combinations that are listed here. I didn't show you the third study of niraparib. But what does this mean? This means that in patients, certainly with a DNA damage repair mutation, the most important one being BRCA1 or 2, that these patients should receive a combination of an ARPI plus a PARP inhibitor. But similar to the story I've been telling you before, people don't get tested. This is a real-world evidence study, actually from the Flatiron Group, that shows that about 60% of patients never get tested for these mutations. So as of now, in order to be a candidate, you have to be tested. And you can see that there was a little bit of a blip down during COVID, but in general, only about 40% of patients nationally get tested for DNA damage repair mutations. So if you don't get tested, you'll never be able to benefit from the treatment. Okay. I think if we haven't had a PSMA PET talk for this group, I hope we do have one soon, because it's completely transformed the way we treat these patients. I've been taking care of prostate cancer for 25 years. PSMA PET has completely changed the way we visualize prostate cancer. Now, this is a clinical states model that I've shown many years now. If you present with clinically localized prostate cancer, you have radical prostatectomy by Dr. Kim, and you're cured, or you get radiation and you're cured. But if you aren't, and at least a third of patients are not cured, they go through these disease states going from left to right, where you might have a rising PSA and then you develop metastatic disease like I talked about earlier, which is on the bottom there. At the top, though, there's this interesting state that we defined as non-metastatic, but hormone sensitive and then castration resistant. What does that mean, non-metastatic? Well, it doesn't mean that they don't have metastasis. It means that we can't see it with traditional scans like bone scan and CAT scan. That's really what it means. It means that our imaging was not able to detect what we knew that was cancer progressing. How do we know that their cancers were progressing? Well, we have a biomarker that I started this whole conversation with, PSA, that even though it's very controversial as a biomarker for screening, it is not controversial at all as a biomarker for monitoring. We use it all the time to monitor whether patients are progressing or not. So as I said, we've actually gone through this state where we actually used to use bone scan and CT scan, but we've completely shifted to the use of PET scan with CT. Why? At least I have. I was on a panel, I was sitting there and I said, I don't do bone scans anymore. And, prominent urologist, kind of tried to berate me for it. But in truth, if I'm able to get a PSMA PET scan, it is far superior to what information I might get from a bone scan. Now, PSMA is an interesting transmembrane molecule because it's not just an imaging molecule, but it is a therapeutic one, as I'll talk about in a second. It's highly expressed in prostate cancer, but particularly almost 1,000-fold in metastatic disease. And one of the issues is that this new imaging agent became available relatively recently. And you can see here, I listed the timing when it became available, 2020, 2021, 2023. These are 3 different types of PSMA reagents. And so in a very short time, we've put a lot of pressure on nuclear medicine to be able to get these scans for our patients, because from the point of diagnosis all the way to the point of advanced disease, this is helping guide exactly where the cancer is in a much more sensitive and specific way than we were able to do with imaging like bone scans or CT scans alone. And it is it's expressed on other organs, particularly the salivary and lacrimal glands. You'll see on some of the images I show you, which is important because of the toxicity of drugs that target it. So they get dry mouth, for example, and the kidneys can also sometimes take up some of these drugs. But it is a really important and excellent target. So, we do know that concept of non-metastatic is a disappearing disease state. So there were drugs that were approved for non-metastatic castration-resistant prostate cancer, but in this study from the UCLA, when they looked at patients who were non-metastatic, that is, they didn't have cancer on a bone or CT scan, and they did a PSMA PET, 98% of them actually had a positive PET scan. So that's not non-metastatic. It means that your old scan was no good. And so it is a disappearing disease state in the advent of the PSMA era. There was a prior test that was available a few years before called flucyclovine. Flucyclovine is interesting because it is a metabolic scan. It's an amino acid that we were using before PSMA became widely available in the United States. And this was a head-to-head study comparing PSMA to flucyclovine. And you can see that PSMA was 4.8 times more accurate in terms of detecting prostate cancer. So again, you can't treat what you can't measure, right? We have PSA, we can measure that. That's a very simple, quick test that we can order on these patients. It's not perfect. It doesn't give us all the information. It certainly doesn't tell us where the cancer is. And that's why PSMA PET in particular has really transformed the way we think about this disease. And this is a prelude to the next section of my talk, which is really therapeutics. Because as you see on the left, you can see a patient with metastatic disease who has a positive PSMA PET scan. You can see the areas in his bone that light up. You can see the salivary glands up in the upper part of his head. And you can also see that his kidneys light up because it's being excreted through the kidneys, and some is collecting in the bladder. On the right side, you see that FDG PET, which has been around for many years and really lights up with the advent of glucose, and is very useful in diseases like lymphoma and lung cancer because those cancers are very proliferative and use quite a lot of glucose. That sometimes, traditionally, FDG PET was not useful in prostate cancer. Traditionally, we haven't used a lot of it. But you can see that, in fact, there are some cancers, including in this patient here, where some of the cancer cells do express PSMA, but some don't, and they only express FDG. And that's, as you'll see in a minute, that's a real issue as we learn more about the use of these imaging techniques. So the last section of my talk is really going to focus on this era of targeted therapy. I already started by saying androgen receptor pathway inhibitors are targeted therapy, and that's true. But in fact, we're moving to an era of radioligands, bispecifics, and beyond. So this is really, in this case, I'm going to talk about LU177 PSMA, but we're also going to talk about all the treatments that I think are on their way. So this was a New England Journal paper just 3 years ago now called the VISION study. And it really shows you how PSMA, in particular a ligand called PSMA 617, binds to the cancer cell and delivers a radioactive payload. In this case, LU177. That's a beta particle that is lethal. So you remember the imaging I showed you earlier was just to see the where the cancer is. But if you attach it to a radio ligand that actually is endocytosed by the tumor cell, then it destroys that cancer cell. That's the idea. So it's like a smart bomb technology to take PSMA and then deliver a radioactive particle. And this is a trial design. You had to just have one positive PSMA PET lesion. And we can talk a little bit about the nuances of this, but this makes it very simple. When you're doing large randomized trials, keep it simple. If you don't keep it simple, it's very hard to accrue patients. And the advantage of this treatment is that the patients could have had it anywhere. It works wherever the cancer is. It works if it's in the bone, in the lymph nodes, in the liver, anywhere. And the patients were randomized. These are patients who had already received the standard of care at the time, which included chemotherapy with a taxane or an ARPI or both. And they were randomized to receive standard of care therapy, which was not further chemotherapy but anything else, versus this treatment, LU1776 PSMA. And you can see here on the left, radiographic progression-free survival, hazard ratio of 0.40, 60% reduction in risk of progression. But more importantly, overall survival, 0.62 hazard ratio, 40% improvement in overall survival. And we have seen some dramatic responses to patients with this treatment. It is given here, and it has transformed a lot of my patients' lives. It is not curative, at least in the states that we're giving. Remember, we're giving it at very late stages right now. So we'll talk a little bit about what's being done to move it forward. So if you look at PSA response, that's a very common way that we measure how efficacious a treatment is. And you can see that if you use standard of care alone, about 7% will have a 50% drop in PSA. But if you use this LU177, it's about 46%. So again, this is not a treatment that works in every patient. We can talk about some of the nuances there, but this is a group of patients who had no other therapy available to them and who were likely to progress and die. And we definitely see exceptional responders. And what you see here in this patient is on the left side, his PSA was 880, and he had diffuse bone metastasis, you can see there. And within 1 month and then 3 months, which you see on the second to last and last panel, his PSA has gone down to 30, and his PET scan is pretty much clear, almost completely clear. And we've seen some complete responses with these treatments. So it is a smart way of delivering targeted radiopharmaceutical therapy. But as I mentioned in that earlier graphic where I showed it next to FDG PET, there are still patients, for example, who don't express PSMA. That's what you see in the left panel. Or patients who have discordance between PSMA and FDG, either in bone in the center panels or in the right. And you see I put PSMA next to FDG in each of these, and you can see that in some patients, the FDG PET is showing tumors that don't make PSMA. This is also probably a way in which these cancer cells, it's like the Terminator. Sometimes you shrink them as many as you can, but the cancer cells that recur don't express PSMA. And this treatment will not work if your tumor cell does not make PSMA. The side effects are almost what you'd expect. Because it's a radiopharmaceutical, we see bone marrow suppression and fatigue. And the dry mouth is unique to this treatment because, as I showed you in some of those graphics, you see this uptake in the salivary and glands. So what about moving this treatment earlier? Like, why are we waiting until after the patient's progressed on chemotherapy and has the amount of disease I showed you? Well, that idea is obviously moving forward. And this was a study called PSMA-4. This is before chemotherapy. And you can see it's the same randomization. You could either get another ARPI or you could get this LU177. And you see on the left side a very strong PSMA PFS benefit. So really a doubling of the time it takes to progress. But on the right side, you don't really see an overall survival benefit. So this is one of the reasons that the FDA has not yet approved this. This study was presented, you can see here, in 2023. And we've seen this data for quite some time. But it's expected that the FDA will actually probably approve this in patients who have not yet received chemotherapy. But it's, again, a subject we don't fully understand. Why aren't these patients benefiting in terms of overall survival? And then the other question is, if these are all patients with metastatic disease, why wait till they develop castration resistance? Why not just treat them up front? And this was a study from Australia where they gave them 2 cycles of PSMA treatment in addition to hormones and chemotherapy. Remember I told you in MHSPC combination therapy with 2 or 3 drugs is the standard of care. So why not just give them this 2 treatments of PSMA in addition? And they looked at this endpoint, which was after all the treatments done, a year later, who's more likely to have a low PSA? And it was actually, you were 4 times more likely to have a low PSA a year later. So it suggests actually that giving this treatment up front will have a long-term benefit. Now, there's another study giving 6 of these cycles, 6 of these treatments. If you give a treatment like hormonal therapy or chemotherapy, then the target starts to go away. Will giving 4 more of those cycles of LU177 get rid of more cancer? It's not clear. In fact, when we give these treatments to patients who have a negative PET scan, it doesn't work. It only works if the target's there. So I think what these studies suggest is earlier use of these drugs does matter, but giving it indiscriminately probably doesn't. So this is my summary of radioligand therapy. And by the way, this is a very hot area for drug development. People are very, very interested in replicating this because right now it's just 2 diseases where RLTs are actually approved. One is prostate cancer, like I showed you, and the other is neuroendocrine tumors, okay, which are even less common. But people are very interested in this type of approach in bladder cancer and breast cancer and lung cancer. And I think the ability to deliver this type of radiopharmaceutical treatment, I think, will hinge on how good those targets are. We happen to have a really good target with prostate cancer, which is PSMA. The other interesting thing that you'll hear about is alpha particles. So, I'm not a physicist, but there are better ways of delivering a lethal dose of radiopharmaceutical that are more able to kill these cancer cells with less toxicity. Okay, so the last part of my talk is really about immunotherapy. And, it's hard to believe this was the breakthrough of the year in 2013. So we've been living with this now for almost a dozen years. And of course, lung cancer is the prototypical disease, along with melanoma and kidney cancer, where immunotherapy has made important differences. But prostate cancer actually was one of the first diseases where a checkpoint inhibitor was tested. This was CTLA-4. And you can actually see that there was a suggestion that some patients might benefit from a checkpoint inhibitor, even in prostate cancer, but it was never developed further. This was predating the use of PD-L1 or PD-1 inhibitors. But there was a suggestion that maybe some patients with prostate cancer actually could benefit from checkpoint inhibitors. But in the end, the only approval for checkpoint inhibitors in prostate cancer right now are in TMB high or MSI high tumors, which, as you know, are highly mutated prostate cancers. Prostate cancers in general are not highly mutated. The prevalence is probably around 3 to 5%, and the rate of response is about 50%. But some of these are durable. You can't really see the bottom there, but the progression-free survival for those with very high TMBs, you can see from upper to lower, the highest TMBs, you can see that they are not progressing after 2 or 3 years, some of these patients. So again, it behooves us to check for evidence of tumor mutational burden or MSI high or unstable disease. But I think the real, that's a very small percentage of patients. So, I probably have seen 1 or 2, even though I have a very big practice, is really taking a page out of the PSMA handbook and to look at bispecific T-cell engagers, so-called BiTEs. So remember, if you have a target and now you can deliver a radiopharmaceutical, maybe you can deliver other things like T-cells. We know that T-cells are the things that kill cancer, right? Why don't they work in prostate cancer in general, like in this curve? Well, probably because they don't know where to go. So if you can be smart and deliver the T-cell directly to the cancer cell, maybe you'll have a better outcome. So this was one of the first BiTEs that certainly got a lot of attention. This was now 5 years ago. And you can see that a majority of patients receiving AMG 160, which was a PSMA-directed bispecific T-cell engager, actually had a PSA response in this waterfall plot. It had some toxicities that really killed this drug, but there was this, there are a bunch of other ones that I showed you on that first slide. And this is also something that is quite, I think, exciting and interesting, but I think it reminds us of the toxicity. It's interesting. We'll see the same drug used in breast cancer and lung cancer and prostate cancer, and sometimes we'll see more toxicity in prostate cancer patients. I don't always understand why. I have a theory about it, which relates to androgen deprivation, but we do see more toxicity in prostate cancer patients than we might sometimes expect with the same drug. But this is a combination of a bispecific from Regeneron that, again, shows significant responses, especially when combined with a checkpoint inhibitor. But it was toxic, and there were several deaths. So what they've done is they've taken away the checkpoint inhibitor, and they're just using the bispecific alone. And this got a lot of attention last year, a couple of years ago now, a STEAP1 bispecific. STEAP1 is another target, immune target, that showed almost a 60% response rate, again, in highly pretreated patients. And you can see the majority of patients responded. So I think this concept has legs. I think we really know that we can deliver a T-cell to the site of cancer as long as we can control the toxicity. And the last point I would make is really around what we know to be a pathway of progression for prostate cancer, and that's neuroendocrine differentiation. This is a cartoon that talks about kind of the progression from the left to the right of a normal prostate gland to typical adenocarcinoma. Those are the PSA-producing prostate cancer cells that might spread to the bone. And it moves into this so-called neuroendocrine phenotype. Neuroendocrine tumor cells don't make PSA. They are not as responsive to androgen. And what you see by the time they develop pure neuroendocrine prostate cancer is that these cancers may have unusual patterns of spread. They may go to the brain, which almost never happens normally in prostate cancer. And they're highly aggressive. They may go to the liver, for example. And this has been, unfortunately, a way in which our ARPIs and the other androgen pathway drugs that we have stop working, and these patients may progress, and chemotherapy, unfortunately, has a very modest effect. Now, this is something that has broad implications across lots of diseases, because we know actually that neuroendocrine carcinoma is present all over the body. These neuroendocrine cells are present all over the body. And in fact, probably the neuroendocrine type of cancer that we know the most about is in the lung. And so a lot of the things we've done for neuroendocrine prostate cancer has come from our understanding of how lung cancer doctors treat neuroendocrine cancer or small cell cancers. But there is a target here too called DLL3, or delta ligand 3. And you can see here that if you look at staining for DLL3, which is in the last panel, You can see that about 76% of advanced prostate cancers, neuroendocrine prostate cancers, express DLL3. And they don't express AR. They lose AR expression, they express DLL3. So last year, there was a new BiTE that was approved for small cell lung cancer called tarlatamab. And this is you can see they're targeted towards delivering a T cell directly to a small cell lung cancer that might express DLL3. So this has actually been looked at in prostate cancer. And again, you can see that in patients who have DLL3 positive neuroendocrine prostate cancer, that there are some long-term responders. Overall, the response rate was only 10%, but I think this again gets to the idea that we have to find and target the right patients. So these are my last couple of slides. Targeted therapy for prostate cancer, I think we're seeing it. AR is the first target, but we have PARP inhibitors for DDR mutations. MSI high tumors should get checkpoint inhibitors. But we're seeing these PSMA-directed therapies, certainly radioligand therapies, but also these BiTEs. And DLL3 is a promising target for neuroendocrine prostate cancer. So I'm going to end on the concept that I came here for to Yale, which is how are we going to use precision medicine more accurately? Here's one disease, a big disease, that is still lethal for a subset of patients. How do we take what we learn about the patient? And you can see this is from an AACR report, but basically think about the world we live in. These are not men who just come in with one disease. They come in with a background of genetics and lifestyle factors and the epigenome and how they present. And there's so many factors that we don't account for when we try to deliver the right treatment to each of these patients. And I'm not saying that we can account for all this, but we can definitely put people into categories that better account for some of these factors that right now we're not measuring at all. And I think that AI is an area where we're going to learn more about how to bring this information together. This is what I was trying to do at Semaphore when I was there, and what I think we can do here with the multidisciplinary excellence we have in pathology, molecular, genetics, with bioinformatics, et cetera. So, this paper came out a few years ago where multimodal AI, which is really using a combination of histology plus clinical data they used multiple randomized clinical trials. They created an AI score and basically predicted the outcomes of patients. And they actually reclassified 42% of patients compared to clinical risk factors, was so-called NCCN criteria. In other words, they were much more accurate for about 40% of the patients. So we're making decisions based on clinical factors that I mentioned earlier, like PSA and staging. And this AI program was so potent in predicting this and is now commercially available that it made it into the NCCN guidelines this year as both a prognostic tool, which has limited value, but also as a predictor of who should get hormonal therapy with radiation. So I'm just using this as an example of where we're going to go in the future as large language models and information gets distilled into bite-sized pieces that we as clinicians can use. And I'm really excited to be part of that. So I'll stop there. Thank you very much for your attention.
Great. We have time for questions, comments. The floor is open. I'll walk the microphone. Dr. Joseph Kim, and then you can keep the microphone and help me.
Okay, thank you. Thank you, William. This is a fantastic talk. And again, welcome back to Yale.
Thank you.
My question, I just want to kind of probe on your last point about the precision medicine in prostate cancer. Again, in prostate cancer, there may not be the most precise term either, because we are still learning how we define precision oncology in prostate cancer. So, now, as you mentioned, we have a lot of good treatment options available for metastatic prostate cancer. You mentioned novel AR degrader, RP, chemotherapy, PSMA-targeted therapies, and PARP inhibitors. And Dr. Roy Herbst, when it was at SWOG, he designed this master protocol, big umbrella protocol. Are we as a field in prostate cancer, are we ready for things like that? Because if you really make an impact in clinical practice, we have to come up with a good novel trial design. I'd like to know what your views on these issues are.
Yeah, I mean, I think I would love to hear Roy's thoughts too. When we built this graphic, right, that you can see, we did it piece by piece. It was painful, and it was each clinical trial. And the biggest problem with this picture is we don't know what we should do in which order, right? We have all these debates about sequencing of treatments. What you're suggesting is that we move into this kind of bigger thinking, right? This idea of an umbrella protocol or a protocol that's a master protocol that accounts for all of the different heterogeneity. The real reason we haven't done it, as you know, Joseph, is that we don't have the categories for these patients, right? Most patients express AR. Most patients express PSMA. We don't know who responds to chemotherapy. We don't know who responds to some of the treatments that we give. So that is the reason we don't have this. The other thing that's maybe similar or different is that these tumors evolve over time, right? So this picture shows that, in fact, we induce some of these resistance patterns. That's not different from lung cancer, but maybe lung cancer presents with enough categories that you can do a master protocol where you give the right drug to the right person right up front. So I would love to hear if that's what's made the kind of this broader approach successful in lung cancer, Roy.
Well, of course, lung cancer's evolved now with 9 different, genetic defects, oncogenes that we can target that are addictive. So that opens up the door there. I think the area where these master protocols could come in handy is in resistance, either primary or acquired. But you're right, you need to have a dichotomy. You can't solve the whole problem at once. You would need to find patients who are resistant to one therapy. And then, of course, there probably are patients who are probably better off with one drug than the other. And that is precision medicine. And we certainly have the ability to do that here, right? One of the things you'll work on, William, because we have the pathology is amazing. We have the surgical colleagues who will work with us, radiation oncology, and then in a multimodality way, sort of pull that all together. So I think that's a good point, Joe. I want to ask you another question, William, and other questions. Joseph has the other microphone. You're at Greenwich, and you're setting up a service line there. The PSMA therapy you mentioned, is that available there? Is it available throughout our network? And then also the BITE therapy. I just came off a couple of weeks on service, and I can tell you that that's not the easiest thing. Are we administering that at all our centers as well?
Yeah, well, the imaging is available there in Greenwich, and I'm meeting with the nuclear medicine team tomorrow, I believe, to talk about how to make some of these treatments available in places like Greenwich. But it is complicated. I think you need the right expertise in each site to be able to deliver it safely and effectively. And I have no doubt that over time we'll build that. I mean, one of the reasons, as you know, that I came to Greenwich is that I saw its proximity to New York and our ability to kind of apply the great science and the great clinical care we deliver across the whole Smilo network, but in a place where there's a high concentration of people, which is in the New York area. I was in Manhattan for a long time. When I moved to Manhattan, people were like, why does Manhattan need another cancer center? And it turned out Manhattan needed another cancer center quite significantly. There were patients who were really not cared for by some of the well-known institutions in New York City because they didn't have access, because it was such a highly concentrated area. So I think Greenwich represents a real opportunity for us to do research, to do clinical care that's at the highest level. But we'll start with areas of treatment that we know are safe and effective. And in the long run, I think we want patients in Greenwich or in Westerly or anywhere within the Smilo network to get the best standards of care.
Great. Any other questions? Do we have any of our fellows here? I didn't think so. I'm going to sign an executive order to get the fellows. And seriously, we should have our fellows here. This was a wonderful talk, and if anyone's listening online, we're gonna change that. But William, let me ask you: the Precision Medicine Tumor Board, which we started a while back, and then COVID sort of derailed. But I would think that's critical for a cancer center, that we get our scientists and we get the people that know how to analyze the DNA and the epigenetics and pull that all together. You're going to revitalize that, I know. Can you tell us your plans?
Well, I think, first of all, Zenta Walter and Rick Wilson have done a really great job of taking this over from Paul Ader. But I do think that the goal is to kind of not just teach, but really affect the care of all the patients who get this molecular testing across all the diseases that we see. We have an amazing phase 1 program. And in a way, a Precision Medicine Tumor Board is like matchmaking. It's like finding the genetic results that would lead patients to go on trials sooner and faster. We know the biggest barrier, I showed that biomarker slide from the FDA, the biggest barrier that industry has with these drugs is finding patients to go on their trials. And cancer is no longer prostate cancer, lung cancer, breast cancer. It is increasingly rare diseases because they're subsetted into these molecular subtypes. So I think a precision medicine tumor board is really critical, and my goal is to think about ways that we can improve it, make it hybrid, and think about more frequent and really practical discussions so that both trainees and the docs themselves really learn from the experience, including myself.
Great. Speaking of multimodality, we have a chair of urology, Dr. Kim.
William, again, thank you so much for the talk. I just want to go back to the disparity issue with the black men. So, again, I think we, as a field, we've been talking about this for a long, long time. So the suggestions in I read your papers. How do you implement something like that? What are your thoughts on getting it out into the community to make sure that such guidelines are followed? Because there's still a huge resistance in terms of implementing. So what challenges do you see, and your thoughts?
Yeah, it's a great question, Isaac, because sometimes the people who are the biggest evangelists for finding these cancers earlier, like urologists or oncologists, are not the ones talking to the patients in primary care. I think that there's a way to implement a SMILO-wide, Yale-wide program. This is really not a cancer issue. It's precancerous. It's really internal medicine where we try to convey this idea and to create maybe a Yale-wide program for looking at these high-risk populations. That includes black men. It includes men with genetic risk. And I think this publication of this guideline, the reason I think NEJM evidence allowed us to publish it was they recognize this gap between this idea that the USPSTF says there's not enough evidence, and now we have something that can justify a program where we're more aggressive about screening black men. So I want to certainly sit down with you and your department, but also internal medicine, primary care, and AAFP and ACP, the American College of Physicians, they're kind of still against screening. And this is the problem. Risk-adapted screening is the key. Don't screen everyone. Don't screen the 90-year-old guy who comes in a wheelchair. But a 50-year-old or 45-year-old black man who has a family history, he's getting the wrong message. I know that because they're not being told that they should be trying to detect this cancer. So I think it is a huge challenge. I think ACS is very interested in creating the toolkit to be able to help places do this, and that's, I think, another source of information.
Any other questions? I think we are at the end of the hour. I'll just say that this is a wonderful example of what Comprehensive Cancer Center does. We go from the patient access, bringing people in and getting them screened, taking them all the way through to new therapeutic options. We have wonderful surgery, radiation, a large number of medical oncologists. Dan, yourself, Joe Kim is here, many others. We have Samir Azadi coming from New York, who works on plasticity, right? Who works on the development. So we have so much that we can do here. So you should start thinking about like a spore in a few years. So really great to see everyone here. William will stay up for a few more questions, and enjoy the rest of your day.
Thank you.